It truly is your show, as you may ask anything medical, and we'll do our best to answer your questions tonight on Call with the Prairie Doc.
Starting this season, we are offering a Facebook Live option for our viewers to still be able to watch the show during the regular broadcast times on Thursday nights and ask questions. All you need is either your laptop, tablet, or a mobile device, such as your smartphone, to view the show. Here's how to do that. First, log into your Facebook account. If you don't have a Facebook account, go to facebook.com and complete the information to create an account. In the search bar, type in Prairie Doc. Make sure to click like on our Facebook page so you can get updates and notified when we are going live. Each Thursday on the Prairie Doc's page, you will be able to see a live broadcast of the newest episode. You can also ask Dr. Holm questions via Facebook Live. All you have to do is ask your question in the comment bar and await a response. If you miss a show live on Facebook, it will be available later both on the Prairie Doc Facebook site or at prairiedoc.org.
Good evening and welcome to On Call with the Prairie Doc. Feel free to call about any medical questions you may have, as it is one of our Ask Anything programs. We're looking for questions. We'll also talk a bit about the quality of life in assisted living facilities and tag along with some of our alternate hosts as they visit with their patients. So first, let's take a look at this week's Prairie Doc quiz question. In a recent Mayo Clinic study, the most common reasons people came to the doctor was for, pick the best answer. Number 1, skin disorders. Number 2, osteoarthritic problems. Or number 3, back pain. Viewers who call in the correct answer, which was the best one, will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in, but we will answer all your questions all night long. And it's your questions that matter the most. As they're called in or sent to us via Facebook or email, call in questions to 1-888-376-6225 or send us an email to the address on the screen. And remember, this is an Ask Anything show. It's an opportunity. Stump the chumps, right? Get us a chance to try to take your hardest question. Joining us tonight, joining us is Dr. Dan Reiffenberger of the Brown Clinic in Watertown and Dr. Kathy Leadabrand, a hospitalist with the Brookings Health System, also from Watertown, but working in Brookings at this time. Kathy, let's start with you. You're a hospitalist, an internist, and then you've kind of turned to become a hospitalist. What is a hospitalist?
Well, it's a growing field that they take care of patients from the time they're admitted to the time they're discharged from the hospitals. And it's developed as medicine in general has become so much more complex. And we, as a general internal med doctor, I was doing clinic and doing hospital, and we were doing call at night, and we found ourselves increasingly pulled in all directions and trying to keep up with his vast wealth of knowledge in both places. And so it's been a way to kind of get rid of some of the chaos and try to focus on the hospital patients.
And it gives you a lifestyle that's better.
Yeah, it's helped lifestyle, and I think both for the people working at the hospital and for the doctors in the clinics, I know that the patients in the hospital have wanted to keep that relationship with their doctor, and I know I missed a lot of my patients that I left at the clinic, but I think in the long run we really try to communicate with the doctor, give a summary of what we find in the hospital, and it's become a rule pretty much. It's developing in every community across the state and nation.
And it truly has helped us on the other end too when we're in the clinic.
So Dan, you're a family physician.
I'm a family physician.
And you're doing outpatient only. You're not doing the hospital
Correct.
anymore. I mean, you
Correct.
used to do the
Used
ER and the
used
hospital.
to do it all, yep. So now I'm just in the clinic, so now I'm not making 3 different trips to the hospital every day, back and forth, trying to juggle. From a quality standpoint, my expertise can stay in the clinic and your expertise can stay in the hospital. We don't have to try to do everything all the time. So it's been a huge improvement from that part.
How about your quality of life?
No question. Improvement in quality of life. I mean, we actually have a life.
Yeah.
That,
And you know, it's as medicine's gotten so busy and so so complicated. It's important for the doctors and the caregivers to be healthy just as well as their
Right.
patients, or they can't do
right,
a
and
good
you
job for
can't
their
keep up on
patients.
everything. It's impossible.
No.
And I guess I should say too that hospitalists, another focus is not just on the patient care in the hospital, but at looking at the systems and trying to improve safety and quality of care and work as efficiently and use the resources as judiciously as we can.
Well, I mean, the classic story there is that acting like a pilot. You have a checklist, you go through all of the things, you do the systems workup so that you don't miss things.
Yeah.
And that's a good thing.
Yeah.
But there's some downside to this. Dan, I mean, what is the downside of splitting the outpatient and the inpatient work up?
We start losing some of that continuity because we're not taking care of them when they're in the hospital anymore. So we're trusting somebody else to do that and take care of our patients, and trusting that they would do what we would do and then give the information back to us so that we can pick up where we left off. But that was probably the hardest thing for us to give up, is we had to let somebody else take care of our patients.
Right. That continuity is the issue, but
Right.
it's not a big problem if you call him and talk
Right.
with
If we
him
work
and say,
together and the communication is
an important
continued,
issue.
okay, it can work for everybody then.
All right. So let's talk about a few other things. One of the things that you would like to talk about is an exercise issue. I mean, we're talking the most important things that keep a person healthy.
Yes.
And so explain to me in your mind, if you were going to do a formula for health for anybody, what would be that formula?
Well, I talk to my patients, every single one of them every day, talking about diet and exercise.
Diet and exercise.
Diet and exercise, both, the dynamic duo. So part of it as far as with it is if anybody thinks that they can stay healthy and maintain things and not work on those 2 aspects of it, then they're just kidding themselves. Okay, I have no problem working on the exercise part myself. Diet, I struggle with. I'm always having to work on that part of it. But every single patient, when I'm going over their labs and we're talking about it, the line out of my mouth is, I'm going to talk to you about working on diet and activity till you're not here anymore. Because
Right.
it's important till we're not. And so I try to set that example by doing it myself.
Right.
So,
You know what, they have criticized physicians, and rightly so, I think, through the years, that we are pill-oriented. Pill, you've got a problem, here's a pill, and we haven't been doing enough in the direction of a lifestyle.
right.
And I really,
Right.
don't you think that that's true?
Yeah,
I mean, the
yeah.
lifestyle, how important do you think the lifestyle is?
I think, you know, it's completely important. We were talking earlier that, well, as I see it, as people, you see people really diverging in their middle years. And those ones that did do it right, exercise and really watch their diet, have a better older age for the most part than the ones that don't. And it's never too late to try and start.
And it doesn't have to
you know,
be, an hour and a half every day.
No.
Yep. And
No.
you know, as personally, I've struggled with it too. And some of it is, you know what to do, and you know what to eat, or you know that you need to exercise, but trying to figure out how to make that a priority, how to keep that habit. And there's a whole field of research in trying to help people, you know, start out in little steps, maybe do one thing for a month, and then add on to
Add
it.
on it. Build
So
onto it. Now,
there's
you
a lot
were-
of good resources out there.
Yeah, there is. Let's hear about your exercise program. I mean, you're how old? Can I ask you?
I am 53.
Okay, and what program are you doing at 53?
First I exercise every day, but I created a program through Brown Clinic called Strive to Survive. And the Strive stands for Securing Time for Regular Involvement in a Variety of Exercise. And so we created this part as far as with it to help promote that activity. Well, I started to see, okay, well, how many days in a row could I exercise without missing a day? Well, as of today, I'm at 3,725. So my 10-year mark was in October. So
10 years of
10 years.
exercise in October.
Right.
Congratulations.
So, I mean, I had an attending doc when I was a medical student, well over 300 pounds, and the cigarettes were hanging out of his pocket, and he would tell his patients every day, you need to lose weight and you need to quit smoking.
Yeah.
Now, I would ask my patients, okay, how many are actually going to listen to him?
Right.
Okay, I can't do everything for them, but I can at least show by example that I'm going to at least make an attempt as far as with it. You know, and it's the same thing when it comes to pills. Everything has side effects with it. So I'll ask patients, okay, would you take a pill if it could, in the long run, make you stronger, improve your cholesterol, improve heart disease, give you more energy, and has side effects that it might make you sweat a little bit more, can increase your heart rate, might make you a little bit more tired to start with, but then it'll build up. Would you do that? Okay, and then I hit them with, okay, that pill is exercise.
Yeah, here it is.
So-
It's
Well,
free.
and I think,
It's
and
free.
the depression.
And it's right, and it's free.
And depression
And
is
depression and
Right.
anxiety, it's such a potent
Right.
treatment for that. I think they compared it to common one, sertraline. They compared
equal.
Exercise and Zoloft or sertraline side by side, and they had the equal benefits. So
And if you do them both, you've got
Together.
double whammy. I can't agree with you more. I'm glad you brought it up, and I'm a regular exerciser. I don't know if it's 10 years, but I walk to my restaurant where I do my reading and writing in the morning, and I get an hour there. I do weights 2 or 3 times a week, and I run 2 or 3 times a week, and I've been trying to do that through all of this treatment that I've been going through for cancer, and I've been pretty successful, and I'm getting better. I'm getting better now,
Perfect.
stronger now. So
Perfect.
that's a wonderful thing. We've got a few questions. Let's take those. And we do appreciate these questions. Thank you. A man from Sioux Falls wonders if there is too much hype about modern medicine. Has medicine really gotten that much better? I mean, I think there is hype to suggest that we are better. I think the real strides are huge in oncology and cancer
Right.
therapy.
Treatment-wise or capabilities of lengthening life duration. But we could debate on and on as far as improvement-wise, otherwise on some of the things, because I'll say some of the things we've gone backwards because we're not oriented as much now with this computer age and technology and everything else. We get so hung up on the technology part with it, we forget to put our hands on the patient.
Yeah.
So from that part, we have made a step backwards from what we used to do
I
more
completely
of.
agree there, because, you know, through the ages, medicine, the patient with the doctor and the patient, that relationship was sacred, and we, you know, we really respected that and wanted to kind of protect that, and that's really, to some degree, been eroded when we spend our time on the computer and we're putting in data and we're losing that connection.
Yeah, and I think also we have really moved in a direction of pills. You know, it's so much easier to just prescribe a pill and then see the next patient prescribe a pill.
Yeah.
And, you know, and then they end up with way too many pills, particularly
Right.
in the nursing home they have.
But
Right.
that said, you know, I remember back in residency taking care of people with heart attacks, and they were what we called cardiac cripples. Their life was ruined after a heart attack, and
Yeah.
nowadays there have been so many advances that to some degree really help people's quality of life, or when you think about antibiotics to a degree,
Really have
antibiotics,
saved a lot of
you know, have
lives.
saved a lot of lives.
And there's surgeries that have made a huge difference. That, I mean, you know, you have an appendix
Right.
ruptured.
Right.
Well, you know, medicine's been too.
Right.
You know,
Right.
Or maybe we better take him to surgery and
Right.
save his life, and that's
Right.
what we do. There's a lot of
There are
differences
too
we
many
make.
different aspects as far as with it, both good and bad.
Right. I did want to say the issue of nursing home and too many medicines in a nursing home is really a deal, and we are working on it. We're getting some pressure to do a better job in that regard.
Well, one of the best advice I ever got was from an experienced physician who said, you know, you should challenge yourself each time you round to take away a medication.
Yeah.
And you find, and I still find it in the hospital, patient may come in and they're on several medicines to treat side effects of other medicines.
Right.
Yeah.
Constipation's one of the biggest.
Right.
Yeah.
But swelling in the legs is another, and
Right.
so that's my first question I ask, could this problem relate to one of the meds they're on?
Right. I take the time when they get sick enough in a nursing home that they come into the hospital. I stop the
All
pills
non-essential?
and just start just the bare necessity, So with that, for some, the thought of moving to a nursing home is terrifying. However, the new styles and procedures used in modern facilities go a long ways toward calming those fears.
Nursing homes have a stigma attached to them. And so, back in the 60s and 70s, nursing homes were not great, and they maybe didn't do a great of a job as promoting health as they do now. So we have what's called a household model of care. And so what we have are 6 different households, and they're set up very much like a home environment. So we have a living room, dining room, kitchen area. We have family dining rooms for our families to come in and have a special meal with their loved one whenever they want. We have courtyards. We have all private rooms except for 3, which are set up for semi-private rooms for couples. A lot of folks coming in and spending a lot of quality time with their loved ones here. Some facilities are set up for that and some aren't. We have a ton of physical space here. Folks here do extremely well. They typically come to us when they can't necessarily do the things that they could before. And typically we're seeing folks in the mid to upper 80s now. And so when they come to us, they're needing that extra help with maybe their normal ADLs, and that's activities of daily living. We have PT, OT, and speech on site here to enable their physical abilities. We also have restorative programs here too as well, and so we get them going on that, and that really does promote healing. Yes, it is possible for 70% of folks with dementia to stay at home, although it just really depends on what level they are in their dementia process. If folks are further along in their dementia process, then that's not a good thing. They're wandering, they're unsafe in the home environment, they're leaving stoves on, fridges open, they're maybe not eating as well. In the nursing home arena, we really work with those individuals, and a vast majority of our folks here do have dementia, some sort of dementia, and we integrate them in our population, and they do really quite well. We do have people that will help you to activities, and they'll help you into the restorative room and ensure that you're doing physical activity. Where at home, maybe you're not getting that push and that extra drive to do those things, but then again, if you are getting those types of services in home, like your home health services, or if you have a neighbor coming in to help you, or if you have a loved one still at home, CMS has a 5-star rating on all nursing facilities right now in the country. Go to Medicare.gov and check out the 5-star rating. That will give you a snapshot of what the facility runs like and really how they're doing. But the best way is to really come in the physical doors, walk around the facility, quiz the staff, quiz the residents, really get a good picture of what you're going to bring your loved one into. And I think that's really the major way of really understanding how a facility operates.
This is your show. Your questions are key to the show discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. And we are getting questions. I did want to respond to what Jason talked about there. Thank you, Jason, for that beautiful interview. The question is, people have this terrifying fear of nursing homes. Is that justified? Kathy?
Well, of course, you don't want to leave your own home, but a lot of times a patient's faced with if they're not ready to go home from the hospital, or maybe they're just getting to the point they're struggling in their home, then they're not going to spend as much time in their own environment anyway. And I explain it, there's a lot that go temporarily to the nursing home before they end up there permanently. And in the old days, people would stay in the hospital 2 months for maybe whatever they,
right.
Like for a heart attack, I think one of the presidents stayed in the hospital 45 days.
Yeah.
Nowadays, they might stay 4 days. But if they're weakened from an acute illness, then nursing homes can really have a role to help rehabilitate them as a step closer to home. And if they're struggling and lonely and forgetting their medication, sometimes it can be they don't realize it at the time, but often it's a huge relief to delegate that to somebody else, and they can just focus on enjoying time with their family and visitors.
Right.
And
I like to transition, if they're not well enough, I transition them to assisted living if
Yeah.
I can.
Yeah.
But then sometimes the nursing home. And then I'm always trying to get them home if I can. I mean, I think
Right.
that's, once you're in the nursing home doesn't mean you're there forever.
Right. I mean, and a lot of that fear is because of the unknown. So they're giving up some of their freedoms from home to end up going into the nursing home. But a lot of them, as far as with it, they're just sitting at home.
Doing
They aren't
nothing.
interacting. They don't have any social interactions with anybody. And that's what's really good about them now is there's continuous activities going on all the time.
You can't have
Yeah.
but a great time at a nursing home.
And, you know, and there's people there their own age to communicate with and talk with and to be around
friends.
and
That
make
understand what they're
right.
going through.
So a lot of that fear, like I said, gets settled down once they at least start to figure out a little bit what this really is like. Some of those are from those old days.
Those old
Yeah.
days.
Yeah.
And in the hospital too, they forget often if they've been there a while with a serious illness, it's a benefit that they deserve that they've invested in
Right.
that
Why not?
they might be wasting if they
Right.
don't take advantage of that time to get stronger too.
So we're doing questions, and I make the answers pretty quick because we've got great questions coming in. Thank you, and we'll go from here. A woman asks if the doctors know of any new treatments for Parkinson's disease. Dan.
At least as far as medications that can take by mouth, there are several, at least as far as what that can end up having improvement versus the traditional carbidopa, levodopa as far as with it. Anything new beyond that, truly, I'm going to get the neurologist in on it for if there's anything else more from beyond that part of it.
I think the big thing that I've noticed new is all the physical therapy, the big movement.
Yeah.
They can learn to do the big
which is
movement.
back to the diet and the exercise aspect.
there
of
it is,
things as
diet and
far as with it,
exercise.
where all of it has a component with it. Yes.
I obviously
Yeah.
don't have Parkinson's disease because I'm still hitting things behind
Yeah.
me when I'm talking.
Yeah,
I've got that illness.
it's just one of the, I think the neurologic diseases are one of the toughest things to treat. We don't understand the brain as much as we do other organs, and we're kind of behind at times still.
I don't think
and
there's great pills though for Parkinson's.
They don't get into the brain as easily as a lot of the pills, and that's the biggest
It's still a
stumbling-
maintenance aspect.
Yeah.
Yeah, none of it's
So-
really good for
Right.
Parkinson's. A woman asks from Webster, what are the symptoms of gallbladder disease? You're the hospitalist.
Well, typically a patient can come in and complain of right upper quadrant pain, so pain right in their right upper abdomen.
Above the belly button on the
Underneath
right
rib-
side.
Yep, underneath the rib cage. That would be the classic, and sometimes it radiates behind the left shoulder, I think.
Oh, right. Sometimes
yeah.
the left, sometimes
Sometimes
the right.
right.
I know that.
So-
And okay, that's the classic. Does it
classic.
follow food classically?
And typically it'll be called biliary colic, where they get pain or sharp pain after eating, and so that would be the classic, but a lot of times it's sneaky. Sometimes it'll cause a band like chest pain and look just like a heart attack, which we often try to rule that out first. And then some people who, maybe people with neurologic diseases or who are already real debilitated, sometimes it can fester along, and you can even have what we call a rotten or gangrenous gallbladder and not have a lot of symptoms until it gets to the very end of a severe infection. So
I remember Schwartz's textbook on medicine, or on surgery, I think it's Schwartz, that said, well, you can learn about the classic symptoms, but forget about that because they're never present with the classic
And
symptoms.
that's right. And you get nausea, vomiting, weight loss. I mean, part of it is this. You can get a whole constellation of other symptoms.
Sometimes
with
the
it, but
bowels
you
shut
just
down.
narrow it down
Yeah.
as far as with it as you're looking.
I had a guy who had the classic symptoms. Oh my God, it's terrible, severe, and it came after a meal, and then it got better, and they did all the tests, and they were normal. And then he got worse, and then it came again, and episodically, once a month, and then finally, after 3 or 4 months, I said, I'm thinking we take the gallbladder out because it's dysfunctional. I don't care what the tests are saying. And they took out the gallbladder, and it was sick as all get out, and he resolved his problem. A woman from Watertown asked, how do you treat a blood clot in someone's knee? Dan?
Well, in the leg, I'm not sure specifically into the knee itself.
Right, but let's say the calf,
in the
below the knee
calf.
and
So-
extending into the
So
knee.
part of it is you're going to need to be on a blood thinner as far as with it, and it's going to depend on the location of where it is, whether it's a true deep vein thrombosis or a clot, or something superficial with it. There are different blood thinners that can end up being put on. Some of them are very convenient nowadays. It's once a day, and you don't have to continue to keep coming in for blood tests with it, like what we always had for traditional Coumadin with it. But they're going to end up being on that blood thinner minimum of 6 months. But the key point on that part of it is if they truly have a blood clot, why do they have a blood clot?
Bingo. Yeah.
So it's not just taking care of it, but why did they get it in the first place?
And I think we undertreat, we don't use enough ACE wraps and support hose. And I'm a real believer in the 18 to 25 or stronger below the knee support hose for people who have edema in their legs or venous insufficiency and this kind of thing.
And keep active.
Keep
Yeah.
active.
Yeah.
Gee, have we said? We have a question about the newest procedure for treating pancreatic ductal cancer, but next week we have Dr. Trudy from the Mayo Clinic who did my pancreatic cancer surgery, and he'll be our guest. So we'll talk about that next week. A man from Pierre asks if it's okay to take 800 milligrams of ibuprofen every morning. Kathy.
Well, treating pain is a tough deal because there's not a great medicine that doesn't have sometimes dangerous side effects. And if that gentleman that takes the 800 milligram ibuprofen, many people would get away with that with time and not have much problem with it. But there are some concerns. If a person has heart failure, then ibuprofen can contribute to the fluid retention. And there's many people that'll come in the hospital. Maybe they're also taking an aspirin a day. Maybe they got put on some steroids along with ibuprofen for an asthma flare-up, and suddenly they may have some chronic irritation in their stomach they didn't know about, and they're in the hospital with a bleeding ulcer.
In the stomach,
yeah.
Gastric ulcer
Yeah.
bleeding or bleeding lower or as well.
And then 800 a day might not do it, but I've seen some people who are taking it twice a day or 3 times a day, and they're on, this is an example where you're giving medications to treat a side effect of another. They come in and their blood pressure's high, and they're on another medication. They get a blood pressure med, maybe 2, maybe 3.
To treat the hypertension from the ibuprofen?
Right. And then they're swelling in their legs both from the ibuprofen and not from often from the blood pressure med, so they get a water pill for that.
Right.
And so suddenly, so there are issues.
You have to know everything else as far as their history and what else they're taking.
They
what
may
other
not even
health
tell
problems.
you that they're taking ibuprofen. They can get it over the counter, right?
So that's why I specifically ask when we're going through their meds, okay, anything over the counter, leave, ibuprofen, anything, because it makes a difference.
But you know what? We went away from the non-steroidals. These are called non-steroidal anti-inflammatory NSAIDs. We got away from NSAIDs and ibuprofen because of the same complications we're talking about, right?
Yeah.
So what did we turn to? We turned to opioids, the narcotics. And now, more people are dying from narcotics every year than car crashes or gunshot wounds.
Yeah.
So we've got to take
So I think you've got to find balance, and you've got to use moderation, and you've got to have a good reason to do it.
Right.
And always look for the safest alternative that's still effective enough.
We're going to talk about pain. A woman from Mina asks, how do the doctors feel about the latest and most popular pain medications that have been prescribed that contain opioids? Dan, what do you think about the opioid pain medicines and this whole status?
It has turned into a disaster as far as with it. I mean, people come in and they're having pain, and as physicians, we're trying to help with whatever we can in regards to their pain. But the same thing, you have to know what else they have going on and what other medicines that they're on. Sometimes you're going to need them, but they're designed or should be designed more as something short term, not long term as far as with it. That's where the problem comes into play.
And then they suffocate.
And I mean, it's the few patients as far as with it where, like I say, we can write a book on as far as with it for abuse and how it got to that point and everything else as far as with it. But that's where you have to reel everything back in, and when it comes to any medicine, not just the opioids, but why are you using them in the first place?
Yeah.
And what is the benefit you're trying to get out of them? Some of them very legitimate as far as with it, and they don't have any other alternatives as far as with it. But you still have to be careful, and you have to manage, and you have to make sure they're not taking too many and keep track of it, and it's work, but you can do it.
I'm going to say that there's the one group of people that we under control pain is cancer pain. About a third of people don't get their cancer pain adequately controlled. That's an area where sometimes those opioids, that's maybe an appropriate place to use it longer term. But in the short term, you know, the ironic thing is it usually worsens their pain. If they're escalating doses at higher doses, it can actually create more pain. And I think the bigger thing I find, I ask patients, you know, do you really want to be under the control of this? Your pain is going to go into a crisis when the med wears off, so you can't go anywhere. You have to try to get it on the street, and it starts to control their life. And I try to help them take power over it.
That's right. I think we can fail if we don't give the responsibility back.
And that's where a lot of this really has to come into that individual patient and figuring out what else is all going on. There's no across-the-board answer as far as with it.
There's no answers. It's a one-on-one deal.
One-on-one.
Yep. Chester Woman asks if hemp is an effective pain medicine. I'd ask you this. We know that 60,000 people died last year from narcotic overdose, right? How many do you think died from marijuana?
I have no idea.
Hardly any, probably. I mean, there are problems with marijuana use, you know, as it becomes legalized in a bunch of areas. But you know, it has been used to help pain, be an adjunct for pain and also nausea, especially in cancer patients.
Right.
And the data is still maybe it's not completely robust yet, but when you're struggling, again, you try to figure out what is the best, you know, balance to get the best effect.
I think there's a paranoia about marijuana, and it was started by Nixon, who is out to eliminate people of darker color from voting so that he could win an election. I think that there's real history behind why marijuana was placed in next to cocaine and heroin as a category of severe addiction. And I think that I don't like altering mental status and thinking in kids in particular or in people in general. And there's some dangers that's happening, and we see it in Colorado. But I think we've lost an effective tool.
Right, because there can be some very legitimate uses for it.
Yes.
Oops.
All right.
Can I say about pain
Yeah.
too? I think we forget it. We look at the medications for pain and again forget about non-pharmacologic or non-medical ways like acupuncture and exercise and massage and
antidepressants. Antidepressants.
Yeah.
That's right.
Okay, I've got to move in this direction. Sorry. Dr. Andrew Ellsworth is one of the docs who helps us out in this program when I'm away. Let's take a moment and get to know Andrew a little bit more.
I'm a family doctor, and so I am blessed to see a variety of people and patients, and I get to take care of whole families, from babies to adults and to elderly, and seeing people in the nursing home and in the hospital. And so I get a nice variety of my practice and really get to establish the relationships with patients that make it all rewarding. Every day is different. Some days maybe we're seeing more patients as needed that are coming in or are sick that day. Some days it's more physicals and routine visits, but there's always even then some sick patients that we get seen, and it just a variety is the spice of life, and that's what helps keep my job rewarding and interesting. Now that I've been in practice for 5 years, it's so fun to really deepen those relationships with people and to help them through troubled times and get to know them even better that way. And then just see them for the little things too, and then help them when something else comes up. I recommend everyone come to see the doctor at least once a year for an annual physical. That gives us a great opportunity to check up on things, to watch your blood pressure so we can catch high blood pressure early, or watch your weight, or to check for diabetes, or to start screening for various cancers like colon cancer or cervical cancer, or prostate cancer, or breast cancer. Because a lot of these cancers, if we catch them early or catch them even before they're cancer, we can really help and prevent something tragic or something developing. And then it helps to have those visits to help get to know your doctor so that when you are sick, that you know who to turn to, and you have that base relationship already to help you through the process.
So I have 4 heroes from the Brookings Clinic that will fill in for me, as well as a variety of other people from all over the state if I'm not here. And so I'm just glad and planning to do that kind of a thing, because you want this thing to go on way past when I'm here. A man from Castlewood has had an issue with angioedema for a long time. Angioedema. He has had face swelling, esophageal swelling, and tongue swelling. What advice can you give to help solve that problem, Dan?
Need to know what medications he's on, what other health issues that he's had, especially if this has been an ongoing thing, but for sure I would want to know what medications he's taken.
Right.
Both prescription and over-the-counter.
There is specialists in that field.
Right.
The allergist,
Right.
Asthma specialists who really
Right.
nail it.
Right.
Anymore, you're okay with that?
Yeah, just sometimes there's an immune deficiency that can cause it, not just a meds, so they could test for that.
Okay. A man from Springfield asks, are there any benefits to using nitric oxide for erectile function disorder? What are the side effects and can it be harmful? Nitric oxide. Nitrous oxide, I think, is what they've done. And I've not seen anything written about it being used in the long term. I do know that the Viagra and the Viagra-like medications have been a great help to
They're
many
so
people.
much more convenient and effective. And like I said, I don't even remember the last time we would even ever encountered using anything of that.
Right. There's also the rubber band that can go on the head of the penis, and then you have a suction device, and it fills it with blood, and then keep it erect with the rubber band, and that works when other things don't work. And also an injection into the Caverjet thing.
Most of them, you start talking about an injection, and then they're going to
Yeah,
go, what's
I'll go
available
rubber
in the
band.
pill?
There is a woman from Springfield asks, what are nursing homes doing to help those with Alzheimer's? Good question, Kathy.
Well, there are some medications that they will, help
And they're a
dispense.
little help.
Yep.
They give you a little bump, and then you continue the downward
But
course.
I think that interaction, I know recreation at the nursing homes are really important, and singing and the interaction with patients, and I think they're really trying to get out of the sick role and keep them dressed and routine. They a lot of times are in an area where it's maybe more contained, but they're in a routine and
I think that's a
yeah.
huge help for people.
Routine is
with a
key.
Routine,
Yeah.
routine.
Right.
Did you know that of people who have mild to moderate Alzheimer's disease, 70% of them are at home?
yeah.
And some of that care is done by family and relatives, and it's great care, and they're at home, and that's wonderful. Some of that care is not so good.
Yeah.
Right.
And at the very end of life, when they're declining from Alzheimer's, hospice has a big role, and it's underutilized there.
Hospice has a big role, and I think that's important. A woman from Sioux Falls received a kidney pancreas transplant and has been experiencing low blood sugar. Is this common, and what would you suggest to help?
I couldn't answer if it was common or not, but especially if we're talking pancreas transplant with it either, I'm
Yeah.
not sure I would even know where to begin on some
Yeah.
of
I
that
would-
as far as with it. But
I'm wondering what medicine.
what medications taken and everything else, that one, like I said, have to know a lot more on that one
Yeah.
to
Yeah.
answer something
Yeah,
better.
that sounds like that falls in the endocrinology field.
But
so.
if you're on diabetic pills and you've had this transplant, and you're having low sugars.
Right.
You need to be off the pills, or you need to be
And
on
it
a
sounds
lower
like
dose
it worked
of
in
insulin.
some.
It's working.
Yeah.
That's right.
Yeah. A 71-year-old female had a heart attack 17 months ago. Is it sufficient to walk 4 miles a day, 4 times a week, to prevent another heart attack and maintain good health? Wow. I like that. 4 days a week, 4 times, 4 miles at a time. Do you think that's enough?
Well, I know that the guidelines are 150 minutes a week are the guidelines that they say is what gives you the benefits. So that's about, what is that, 30 minutes a day?
30 minutes a day average.
So if you can go past that, and you're working hard enough, I think, to make you a little breathless.
And as long as she's not having chest pains, go for it.
Yeah.
Do it.
I love
Do it.
seeing this. I do like saying that every day you have a commitment, at least a mile.
Yeah.
And it's 12 blocks.
Yeah.
Just 12 blocks. Walk away from your house 6 blocks, come back, and you've done your 1 mile.
Yeah.
Just on the off day.
Keep going.
Keep
Use
going.
it or lose it.
Use it or lose it. A woman from Sioux Falls says, my husband is paralyzed in one leg and is wheelchair bound. What types of exercise can he do? And that really says the question that I've been asked many times. I'm incapable of doing exercise. What can I do? You know, here's one who is wheelchair bound, not up and walking. What can he or she do?
Well, I can come up with some exercise for anybody under any circumstance as far as with it, whether upper body, arm movement, anything else with it, using the leg that you can use, having some help either from the spouse or therapist or a friend or anything else helping to move the other leg with it. But there are all different kinds of other activity, upper body, everything else with it. Just
And
because you're confined to the chair, you can still do some movements.
And that's important.
And
South
anything
Dakota,
is good.
South Dakota may even have, they used to have a pamphlet of chair exercises that you could get online and download. So
Certainly
that
go
may
to
still be
OT or
there.
PT sites and do that. A Facebook viewer asks if the doctors could explain what functional medicine is and what their thoughts about it would be. Functional medicine.
That one kind of stumped us,
Yeah,
I think.
I think to me it's implying more as far as what you're physically capable of doing and how you're going to function, as far as what you're able to move or do. Other than that, like I said, I don't have any other.
Someone
comment
must
or-
have had some form of program of some kind, and function medicine is what they've named it. I mean,
Yeah.
it sounds herbal, non-academic, and I don't know, but I don't know anything more about it.
I'm going to do some research on it.
Okay. Send me a question
Yeah, I'll
and
Google
answer
it,
it back
yeah.
next week. A woman from Brookings has been passing blood clot through her rectum for 2 to 3 months. She went to a doctor and they said it was nothing, but she's still bleeding. What can she do? Now, so rectal bleeding, in my mind, is commonly a hemorrhoid. Not a big deal, not dangerous, right? But I'm always nervous because new hemorrhoids commonly can mean change in the hemodynamics internally. I'd make sure that a colonoscopy
If
had
you
that.
don't look, you're not going to know. I mean,
Yeah.
and if you don't,
You can't assume.
Right. She needs a colonoscopy.
Now, if she's had a colonoscopy in a year ago, was that enough?
A lot of times the physicians will say that, and it kind of depends, again, what she's going to do with the results of the colonoscopy. If they're frail and they wouldn't even want to treat a tumor if it were found.
Right, so it all depends.
Or they don't want to go through the risk of the prep. Maybe they're on a blood thinner that needs to be readdressed, or
Right.
Yeah, well, I'd do that colonoscopy though.
yeah, yeah.
But it's not normal.
Yeah.
It's
Yeah,
not
it's not
normal rectal
normal.
bleeding. It doesn't
Yeah.
go away. I think that needs to be looked at.
That's right.
Man from Ramona slid off the roof and landed on both feet. Whew. He had his left knee then replaced at the Mayo Clinic and has always had pain in the back of his knee. Is there any reason he has such pain in the back of his knees after that accident?
Boy, I'd have to examine him, I think.
Yeah, I mean, you can guess on a few things, at least as far as with it, just from the trauma and everything else. But yeah, that would be one we'd have to actually see and try to determine.
Chronic pain in the knee, if it's been evaluated by a really good orthopedist and probably an MRI, if that's happened, then and they say don't do anything, then I think we need to. Next step is exercise and try to get back to function.
Right. Right.
South Dakota man asks, is Prevagen safe for memory problems? Prevagen. I think that's an herbal.
Okay. And yeah, I don't know on that one.
I don't know. The problem with things that are not prescription medicines is that you really don't know what's in them. And the Consumer Report just did a review about, did either one of you see that this month's Consumer Report talking about the fact that many of these things have that are not reviewed and not FDA approved have something that's in them that they say they don't have, or they don't have enough or too much of what they say they do have. So you can't.
You can market it to say however they want it to say that it's going to do.
Maybe they
too.
haven't gone through the rigorous studies that at least a lot of medications go through.
Prevagen, though, is nothing that I prescribed or you
No.
prescribed.
No.
A man asks, what effects does CLL have in long-distance running or vice versa? Kathy, you know, chronic
CLL.
lymphocytic leukemia.
Yeah, so many people will have high white count for years and not
No
really
problems.
notice
No
any
problems,
problems.
right.
It's a very common. It's an indolent type of cancer of the blood, but
If you feel fine,
Yeah.
do it.
Go for it.
Do it. You're not going to hurt anything else more
and
by
if you
doing
do
it,
need
so.
treatment down the road, you're going to be better able to tolerate the treatment and get
Right.
through it.
We're all in favor of exercise. Did you hear that? What causes restless leg syndrome? We want to run as fast as we can, or we'll do some things after hours. But restless leg syndrome, is it still called restless leg? And when does it go into the back?
Well, I'll take
Yeah.
the restless leg. It's discomfort in the legs. It's often at night, and it's often associated with tingling in the legs, and it's relieved by movement. And
Right.
there are treatments, there's medications for it. I would always, number one, that a lot of people don't realize is iron deficiency is a real common association with it. So we recommend people get their iron checked. But stretching your legs at night,
help
standing
for
on your
restless.
toes or stretching your calves to get the wall, that can really help. And then there are medications that can be helpful too.
Right.
What worries me is that it goes into his back. I think it
Yeah.
might not be restless
Then
leg
there's something else to
Yeah.
look into on that. Yeah.
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 Although
It-
people with pinched nerves in their back may have more commonly
Right.
get some
Right.
restless
Or
legs
there
too.
could be ischemic process, or there could be so I would definitely get this looked into, or a second opinion.
Yeah.
Right.
Woman from Sioux Falls wears support stockings, great, and asks what kind of stockings do you suggest? And I think the 18 to 25 or 22 pound below the knee is, you don't need to go above to get, but I do, what is it? It used to be it's Jobst,
Yeah.
but it's now a lot of different brands.
A lot
Yeah.
of different brands, a lot of
Stylish
different
ones
styles.
with-
Yes.
And there's even devices, sometimes they're hard to put on, but you can go to most medical supply stores and get devices to help you put them on. It's pretty nifty
Yeah.
things.
I
so.
think that's good. A woman from Brookings asks, what is your opinion about putting patients on continuous medication for osteoporosis for a 71-year-old? Is it effective? Is it safe? Is it worth doing?
Continuous medications, if we're talking like Fosamax
Yeah.
or anything with that, definitely can end up being a benefit as far as helping to, again, slow down that process as far as with it. But same thing, everything has to be monitored. Have to make sure at least how they're taking it, they're not going to have any issues with it. But yeah, I wouldn't hesitate at all to end up starting that.
I hesitate, though. I'm not a fan of Fosamax and those, because now they're saying, oh, after how many years?
5 years.
They're having fractures, and so now we're injecting, and we don't really know.
Wow,
what we're-
and again, because you have to have that time break after that part. But part of it is at least as far as for the ones that I've seen as far as with it and preventing, because once you have the compression fractures, you're miserable.
Yeah, I think the
So-
best thing to do is to exercise so you don't have to do this.
That-
That's way better than Fosamax.
Any of this is better than medications, period.
There it goes. We have okay, we've got to go to this. And now for the winner of tonight's Prairie Doc quiz question. In a recent Mayo Clinic study, the most common reason people came to the doctor was for, pick the best answer, 1, skin disorders, 2, osteoarthritis problems, 3, back pain. The correct answer is number 1, skin disorders. It was Bob Broshot, my neighbor, who answered the question correctly. Thank you, Bob, for participating, and a book will be dropped over across next door from your neighbor. We'll be right back after this.
Because they want you to be there for the many milestones yet to come. Because you don't want to miss out on the little things. There are many reasons to get life-saving cancer screenings. 1 in 8 women will be diagnosed with breast cancer in her lifetime. But regular self-exams and mammograms can catch it early when it's most treatable.
Promise?
Promise. 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 Promise.
Make the promise to get screened. Do it for the people you love. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
A friend gave me feedback a while ago. Some people say you're arrogant, but I said no. He's just self-confident, I told them. He followed, we need that in a doctor, but you know, there's a fine line between those two characteristics, arrogant and self-confident. Ooh, that threw me for a bit. After thinking about it, I took it as an honest comment and an effort to allow me a way to improve myself. As a physician philosopher once said, a true friend will help you grow by pointing out your warts. Instead of getting angry, one should take it as an opportunity to get better. What is arrogance? The dictionary's definition is harsh, an offensive display of superiority or self-importance, overbearing pride. I see it in people who treat others poorly, especially those who are lower on some hierarchy. Examples would include an employer who expects sexual favors of some kind, or a prison guard who harasses a prisoner hatefully, or a teacher or parent who supervises a student or child unjustly, or, to make the point, a doctor who treats a nurse or another partner or a patient poorly. I believe nothing indicates the true color of an individual more than how she treats someone who may be lower on that totem pole. I've seen examples of physicians acting this way. When a surgeon threw a scalpel across the room, when a specialist spoke negatively to the patient about their primary care physician, or when a surgical resident treated an inner-city young woman infected by gonorrhea with disdain and contempt. I'm not proud that my profession probably deserves some reputation for being arrogant. On the other hand, part of the value provided by the physician comes when the patient senses that the doctor is competent and knowledgeable. A humble physician is one thing, but an unsure and uncertain doctor is another. Perhaps sometimes I've come off as a know-it-all. I need to work on that because I do not know it all. In fact, it seems the more I do know, the more I realize my inadequacies. My folks came from humble backgrounds and I grew up drilled on the golden rule. The last thing I want to do is to portray myself as a physician who thinks he's more important than someone else. Rather, I would like to be known as a competent physician who cares. Well, a great big thank you to Kathy Leadabrand and Dan Reiffenberger. We really appreciate your coming and being part of this, and you're voluntarily driving down from Watertown, coming out on this cold night to help answer your questions. That kind of willingness to volunteer is the heart and soul of this program. We didn't get to all of your questions for the broadcast portion, but we will answer them live on our Prairie Doc Facebook page. So join us there now for the rest of the questions. Well, it's that time of the year again. The flu season is here. It's hitting. It's here. There have been 133 confirmed cases in South Dakota so far, and 9 of those patients needed to be hospitalized. Have we had them in Brookings?
I haven't. I've seen some relatives, I think.
Okay. Getting your shot now will give you the best protection during the coming months. So that does it for tonight from all of us here at On Call with the Prairie Doc. Felt like it went like bingo. Until next time, stay healthy out there, people.
Their patients range from Persian kings to lowly prairie dogs. The Mayo Clinic, a history of excellence. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen District Medical Society,
Black Hills Medical Society,
3rd District Medical Society, Brookings, Madison, and Flandreau,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.